love to be there. I have been practicing pediatric dentistry for 27 years now, and especially during the pandemic and during COVID, it was just lovely to see children enjoy themselves and have a good time, and a happy time, especially because everyone was suffering so much. We see children from 0 to 18 years, right from toddlers to adults to 18-year-olds, and also adults with special healthcare needs. So we see the whole spectrum. And that's of course my team. Without them, I'm nothing. In 2010, I started a continuing education program called Pedo Pathshala, and we had dentists coming in from all over the India, of course, and internationally, and we teach clinical pediatric dentistry at Pedo Pathshala. I took a break in 2018 to write this book on contemporary treatment techniques in pediatric dentistry by Springer International. It's a clinical guidebook, like an atlas of clinical techniques that handholds the clinician through various techniques. Today I'd like to talk to you about the vital pulp in immature teeth, in teeth where the root is not yet developed. Yeah, and especially in teeth that are traumatized. This can be extremely challenging even for the most skilled endodontists. Immature teeth, immature apices are very, very difficult to treat. In my 27-year experience as a pediatric dentist and in my journey as a pediatric dentist, the one thing that I've found very challenging is trauma in the immature permanent teeth. Traumatic dental injuries can be very distressing, a terrible experience for the parent, for the children who are undergoing it, and after managing the initial distress, the blood and the tears, you really have to know what to do. And in every situation, it's going to be different. So you need to figure exactly what you're going to do in which situation. 20% of children up to 18 years of age will suffer some kind of dental trauma in their permanent dentition. Most dental trauma occurs between 7 to 15 years of age. And remember, at this age, between 7 to 10 years of age, epexogenesis of the permanent incisors is incomplete, right? The roots are not fully complete. So you have a traumatized tooth in a child who's 7 to 10, 12 years of age, and the root is not mature. Now this can be an extremely challenging situation, and you need to know exactly what to do. So why is it so different and so important in that age group? When that tooth is erupting, for that immature tooth to go from there to there to there to there takes at least 3 to 5 years. In that period of time, if there is trauma and you have a pulp exposure and you decide to be invasive or aggressive, you go in and take out all the pulp, you give it an apical seal there, you put in your post, right, and you prep this tooth for a full coronal coverage. What have you done? You have left this tooth extremely weak. Let us translate this into a clinical scenario. That is a 9-year-old child, a very, very young child, and that is the immature tooth that is traumatized. Now if I decide, right, to go in, extirpate all the pulp tissue, right, and then remember, this is not the full clinical height of the tooth. The tooth is not yet fully clinically erupted, right? And you've gone in and taken out all the pulp tissue, you put in an apical barrier there, you put in a post there, and you prep this tooth for full coronal coverage. What have we done? We have left this tooth extremely weak, with poor resistance form, with the possibility of fracture of the remaining tooth structure and possibility of root fracture. Remember, this tooth is just 9 years, this child is just 9 years old. So even in the hands of the best endodontist, you will have this tooth only for the next 20 years. And that child is just 29. They are a young 29-year-old and they will lose that front tooth. So if you are minimally invasive, you will have this tooth for many, many years, right? So our aim here is to be minimally invasive. We must make the right choice because every decision we make has a consequence. And the decision we must make should always be minimally invasive. So I'm going to discuss these minimally invasive endodontic techniques with you today. So what are the endpoints of pulpal response in acute dental trauma? You can either have pulp necrosis, you can have pulp canal obliteration, you can have pulp survival. Now the only time that we must seek to do endodontic treatment is when we have pulp necrosis. When to do endodontics? When you have pulp necrosis. Remember, I'm talking about an immature permanent tooth. We are discussing young, immature permanent teeth where the root is not yet completely mature and developed. So pulp necrosis is the only time you will go and do endodontics. So what would you do otherwise? That's what we're going to discuss today. And what are the signs of necrosis? Here are the signs. Either you will see arrested root development. The root canal walls will not get increased in thickness as you observe the tooth. There might be progressive loosening in a necrotic pulp. You will miss the hard tissue barrier following a complicated crown fracture. There may be absence of periodontal healing in 6 to 12 months, and there may be persistent tenderness to percussion. Now, why are we saying that only in pulp necrosis we should do endodontics? The reason being that the pulp in an immature permanent tooth is very, very different. What is the difference in the pulp in an immature permanent tooth? The pulp of a fractured or a luxated immature permanent tooth can survive and it can heal. Spontaneous pulp revascularization following luxation injury is possible. Root canal treatment should be avoided unless there is clinical and radiographic evidence of pulp necrosis or periapical infection in the follow-up examinations. And regular follow-ups are mandatory so that root canal treatment can be commenced if infection-related inflammatory root resorption is seen in future. Now I'm going to discuss a couple of trauma situations that you will see often in your practice. The first is subluxation. This is very, very common. What is subluxation? It is abnormal loosening, but there is no displacement. The tooth does not move from its position, it just gets loosened. So the classic sign when you see subluxation is you will see bleeding from the gingival crevice. Mobility will be there in the horizontal direction, not in the vertical direction. No radiographic changes will be seen in the PDL. Splinting is not needed in subluxation. And whatever I'm sharing with you is the guidelines of the International Academy of Dental Traumatology, the 2020 guidelines. Splinting is not needed. Soft diet for 7 days and control with an X-ray and sensibility test. And you will see beautiful maturing of that tooth because it is a young permanent tooth. So wait and watch. What if you see a lateral luxation? Now these situations are a little different. This could be accompanied always by comminution of the fracture of the alveolar bone. There will be a slight fracture. So the first thing you need to do is reposition the tooth digitally. So give a local anesthetic. Digitally, gently reposition the tooth in its place. Wrap the gauze around your thumb. Push it upwards and push it in and reposition the tooth. The next you will do is splinting. Splinting in trauma should always be a flexible splint. Splinting should never be rigid because it should allow for physiological movement of the tooth. Only when the tooth moves physiologically can healing occur. So what is the best flexible splint? Is a wire composite splint. So the wire thickness should be 0.3 to 0.4 mm. Place the splint there, and resin is very, very difficult to do because you're going to need to etch, to bond, and there's bleeding, the child is upset, there's salivation, so it's a messy situation. I love to use resin modified glass ionomer for my splints. It's really, really quick. So I use a capsule of resin modified glass ionomer, and that's how I splint the tooth. Now whenever there is subluxation, the splinting has to be for 4 weeks. Now you don't need to remember these guidelines. They are freely available online. The IADT guidelines are freely available. Go online and look for the guidelines 2020 of the International Academy of dental traumatology, the IADT. That's on 4-week follow-up. Those are the radiographs at injury and the splinting, and there you see 2-year follow-up. The tooth is doing very, very well. But what do you see here? You see pulp canal obliteration. Now this is very, very common in an immature permanent tooth where you see a luxation injury. Pulp canal obliteration is almost always a standard sequel in teeth with open apices which have suffered a severe luxation injury. It indicates the presence of viable tissue in the canal. A pulp canal obliteration like this is no problem at all. You just leave the tooth there, it is a healthy tooth. Now what happens if a child comes to you like this? Typically the parent and child will come running to you and say the tooth is lost. The tooth came out, the tooth is avulsed, they can't find the tooth, the child is crying. Most often the parents are crying because this is a 6, 7, 8-year-old child, right? There's blood and saliva everywhere, it's a mess. But when you take a radiograph, you'll be surprised so often that the tooth is there, it is just intruded. Intrusive luxation in a young permanent tooth is not such a bad deal most often. What you need to do is wait and watch, independent of the degree of intrusion. Allow for re-eruption without intervention. It's called spontaneous re-eruption. So that was a tooth in 2011, and there you see how well the tooth is repositioned spontaneously. But there are some rules, because rarely what happens is the tooth may become ankylosed. So it will not re-erupt, so you need to really watch out for it. And if you do not see the tooth coming out, that means the tooth is getting ankylosed. So wait for about a maximum of 3 to 4 weeks, and if there is no sign of movement of the tooth, then you need to orthodontically reposition the tooth, otherwise you will land up with ankylosis. And of course monitor the condition. Now I will come to crown fractures, because crown fractures are perhaps the most common kind of trauma that all of us will see. I'm sure each one of you here in the audience has seen crown fractures. Now there are many things you can do for crown fractures, but remember, this is a young child, so the rule is to be minimally invasive. Because if I am 52 today, I know when I'm 80, God willing, I still want that tooth in my mouth. If I am aggressive in a 10-year-old child, I will not leave that tooth for the child when they are 30, 40, 50. I must do less now, so I leave more tooth for the future, right? So when you have a crown fracture, the crown fracture could be uncomplicated or the crown fracture could be complicated. That means the pulp is exposed. Now, whether it's a complicated or an uncomplicated fracture, the things you need to look out for are tooth mobility, dislocations, injury to the soft tissues, and injury to the adjacent teeth. Trauma is never a single tooth. There will be other stuff going on there, so you need to take a look at everything. Okay? Now, what do the IADT guidelines say? Whenever you have trauma, you need to take 3 angulations of your parallel periapical radiograph. So you take a dead-on center view. 1 minute, I'm not used to the remote, so yeah. You take a dead-on center view there, and then a right lateral, left lateral. The reason you're taking 3 views is to check for root fractures, because often you might miss out on a root fracture. Then you take an occlusal, you can take eccentric exposures. So you always use a paralleling device. If you don't have it now, that's fine, but make sure at some point, excuse me, you get hold of a paralleling device so you can take a good parallel radiograph. And always, if you do not find the fragment of the fractured tooth, take a radiograph of the lip. If the parent says, I could not find the piece of the broken tooth, you must take an X-ray of the lip, because very often, because the orbicularis oris, the lip muscles are so tight, the fractured fragment can go and get dislodged into the lip and you will not know. So make sure you take a lip X-ray. If the tooth fragment is available, it must be reattached. Reattachment of a fragment is perhaps the most minimally invasive thing you can do for that young permanent tooth. Yeah, aesthetics Following dental trauma, there's nothing better than reattachment of the fragment. The technique, what are the advantages? The technique is extremely conservative. You have not touched a burr to the tooth. Imagine, you haven't touched a burr, you just reattach the fragments. So it's so minimally invasive. Aesthetics is excellent because it's your natural tooth, it's the same form, the color, the contour, the translucency, surface texture, everything is the same, right? So that is simply the best for the tooth. And no fragment, I would love to discuss fragment reattachment and the technique, but we do not have the time today, so I will only do the pulp, maybe another time when I come back here. So if you do not find the fragment, the second most minimally invasive procedure would be a direct composite build-up. Because again with a direct composite build-up, you're hardly touching the burr to the tooth, you're just beveling the fracture line and adding. You're not subtracting much, you're adding. Already the tooth is lost. You don't want to subtract anymore, you want to add. Yeah, so direct composite will be simply the best. Now when the pulp is exposed and you have a complicated crown fracture, reattachment is secondary. First, look after the pulp because there's no need to hurry with reattaching. You have to save the tooth first. So look after the tooth, and success of the rebonded fragment is secondary to the tooth success. So first the tooth has to be saved and then the fragment. What is our goal? The goal is to preserve vital non-inflamed pulp tissue that can be walled off with a continuous hard tissue barrier. So what is vital pulp therapy? Vital pulp therapy procedures allow the injured pulp to heal and to continue to function. It encourages continued root development and maturation. It contributes critically to the lifespan of the tooth. What does the procedure involve? First, management and surgical amputation of the pulp tissue that we have judged is inflamed. So we make a judgment call, how much of the tooth is inflamed, and we manage it or we surgically amputate it. I will go into the details. The remaining tissue has to be treated with a biocompatible material. What are the 4 prerequisites? The first is that the remaining pulp is either non-inflamed or capable of healing. Hemorrhage is properly controlled. A biocompatible, bio-regenerative capping material is advised, and a bacteria-tight seal is present. That bacteria-tight seal is very, very important for good healing. Now, how do we know how much tissue to remove and how much to leave behind? We are not doing a histopath analysis, right? So how do we make that judgment call as clinicians? Here are the tips. The remaining pulp tissue is either non-inflamed or capable of healing. How do I predict the degree of pulp damage? What are the decisive factors? The first is the time elapsed. What is the time elapsed from the time of the injury or trauma to the time the child presented to you? Did the child come in 1 hour? Did they come in 10 hours? Did they come the next day? Did they come after a month? That makes all the difference, because when the pulp is exposed for 1 month, imagine the amount of bacteria that's going into the pulp, as opposed to when the pulp has been exposed for say 1 hour, right? The first is time elapsed, and the second is the size of the exposure. How much of the pulp is exposed? Is it a pinpoint exposure or is it a large exposure? So there are 3 things we can do, right? The first is a partial pulpotomy, where just 2 to 3 millimeters of the coronal pulp is removed, then a complete pulpotomy, where the entire coronal pulp is removed, and then an extended pulpotomy. Now, I'm going to discuss this with the help of a few cases, because I'm a pure clinician. I rely on all the good work that researchers do and apply it in practice. So I'm just going to share clinical cases so it becomes easy for you guys as well. So this child came to me with a pinpoint exposure a few hours after trauma, 1 hour after trauma. Okay, so 1 minute, I made a tiny mistake there. Okay, the first situation is a pinpoint exposure and a few hours. You can do a direct pulp cap. Second situation, up to 4 millimeters and within 9 days. Now this is a broad guideline. This is not guideline you close your eyes and apply. Yeah, but this is a broad guideline. Up to 4 millimeters and 9 days, a partial pulpotomy or a Schweck pulpotomy. And greater than that, you do a complete pulpotomy or a cervical pulpotomy. Now this child in 2007 came to me with trauma, arrived in 1 hour, and there was a pinpoint exposure. In 2007, the only bioregenerative material I had with me was grey MTA. I did not have anything else, so I immediately irrigated the area, placed a pellet of sodium hypochlorite, dried it with a moist saliva soaked pellet, placed my MTA there and built it up. Luckily for me, even on 11-year follow-up, the tooth was doing extremely well. Okay, that is how the tooth was in 2007, and that's how well the tooth was doing in 2018. But honestly, as far as I'm concerned, I feel I got lucky. And why do I say I got lucky? Because the most important prerequisite when you do vital bulb therapy is a bacteria-tight seal. You must get a bacteria-tight seal. And when you do a direct bulb cap, you cannot get a bacteria-tight seal. Why do I say that? Because you're not removing any contaminated pulp tissue. There is no space for you to place the material, and there is no space for you to give the tooth a very, very good seal, right? Because you're not removing pulp tissue there. The direct pulp cap dressing material occupies parts of the dentine, perhaps even parts of the enamel, and coronal seal is compromised. The restoration can fail because bacteria could enter, increasing the risk of pulp inflammation and necrosis. So I personally do not do direct pulp caps at all anymore. However, direct pulp cap is still something we must consider. Why? Because it is an excellent emergency treatment. Excellent. So if it is a general dentist, okay, who's not so used to a crying, wailing child, and the patient rushes to the general dentist, the direct pulp cap is an excellent emergency treatment. So ask the dentist to do the direct pulp cap, and then, or if you are busy, you have a very busy day, and the patient has come, because trauma comes unannounced. It's not going to, there's going to be no appointment for trauma. You have a busy day, and the child just has broken their tooth and comes rushing. You can do a direct pulp cap today, and call the patient back after 2 days in order to do your Schweck pulpotomy or your partial pulpotomy. Alright? So the direct pulp cap is a simple clinical treatment, and it's a great emergency treatment. For good prognosis, long-term prognosis, however, you must do a partial or a coronal pulpotomy, and both have similar satisfactory results. This child presented 30 hours after trauma with a pinpoint exposure less than 4 millimeters. So we did a partial pulpotomy or a Schweck pulpotomy. I'm sure some of you are familiar with that. So that is the pinpoint exposure site there. We did a Schweck pulpotomy. Some of these are cases from my book. So you will see I've mentioned that there. So with a high-speed handpiece, cooled with a water spray, you go straight in with a diamond burr at the site of exposure. The approach with the burr should be directed to the exposed pulp 1 to 3 millimeters without widening it. The pulp can be resected to 1 to 3 millimeters. You irrigate with, place a pellet of hypochlorite and then irrigate with saline. The bleeding is controlled, but you do not want a blood clot. Compressed with a saline-soaked cotton pellet to avoid desiccation of the superficial pulp tissue contamination, and you don't want contamination with cotton fibers, so it should be a wet cotton pellet, saliva-soaked. The medicament has to be placed on the healing, non-inflamed pulp, so you must have, the bleeding should be controlled, but you do not want a blood clot. Pulp is healthy if successful bleeding is roughly controlled in 2 to 3 minutes, though this is also now questioned because time may not be a good judgment, and I will come to that very soon. But you should see good bleeding control, but you do not want a blood clot. What are the medicaments? You could put a calcium hydroxide or a calcium silicate cement, an MTA or biodentine. But because this is the anterior tooth, biodentine is better because it discolors less. So I have placed biodentine here, and then I like to place a thin layer of resin modified glass ionomer. Excuse me, sorry. The cavity is etched and bonded, and because I had the fragment with me, I have reattached the fragment. Now this is the Schweck pulpotomy immediately after treatment. That is on 2-year follow-up. If you look very carefully, you will see the fracture line there of the fragment reattachment, but that doesn't matter. This is a 10-year-old child, and this is decent aesthetics. You can always give her better aesthetics later, but remember, you have been minimally invasive, right? And that is the tooth on 2-year follow-up. If you look carefully, you can see a dentinal bridge there, and the root is maturing further. The tooth is doing very, very well. This child presented 24 hours after trauma. Again, a pinpoint exposure, less than 4 millimeters, so we did a Schweck pulpotomy. A Schweck pulpotomy is a permanent modality. You do not need to go back in and do a further treatment after the tooth matures because you have healthy pulp there. If root is growing, that means your pulp is healthy, right? So what does Schweck pulpotomy do? You are preserving the cell-rich coronal pulp. By removing 1 to 3 millimeters of the exposed pulp, the inflamed superficial pulp tissue is amputated, leaving healthy pulp underneath, right? So we've gone there, irrigated with sodium hypochlorite. You can see the sodium hypochlorite there in the canal. Then I irrigate with saline. That's the saline-soaked cotton pellet, and that is bleeding control and no blood clot. Coronal pulp is rich in cells, is more likely to facilitate healing than radicular pulp. Because the radicular pulp is more fibrous, the radicular pulp is more unicellular. So the radicular pulp does not heal as well as the coronal pulp. And that is why Schweck pulpotomy has excellent results. That's the biodentine in place, the pulp dressing material is placed directly. There should be no intermediate blood clot over the non-inflamed tissue after easily achieving hemostasis. Then the RMGIC, the resin modified glass ionomer, the etching, the bonding, and the composite resin. And because I did not have the tooth there, okay, so that is the biodentine plug. I will just quickly, so can you see the layers there? That is the biodentine plug, that's the resin modified glass ionomer, and that is the composite resin. And you can see how open the apex is there. That is the biodentine plug, the resin modified glass ionomer, and the composite resin. That's the last, that's the composite resin, and because I did not have a tooth fragment, I built it up with a composite resin restoration. The ultimate aim is good coronal seal, and that is on 1-year follow-up, that is on 3-year follow-up. Your composite resin may stain, but that's fine, you can polish it, you can redo it. But remember, you have been minimally invasive and you have destroyed very, very less tooth structure. You have added, you have not subtracted. And see how well the tooth has matured. The root is mature now compared to how it was before. This tooth is doing very, very well. That's a long-term follow-up of a Schweck pulpotomy case. And again, you can see how well the tooth is matured at 5-year follow-up. Schweck pulpotomy has a prognosis of 94 to 98%. It has excellent prognosis because the flat fractured surface in a complicated crown fracture allows for salivary cleansing. Do you see it's flat? So there's good salivary cleansing. Food debris does not accumulate. So the pulp tissue remains relatively healthy compared to maybe a posterior tooth where there's a pulp exposure, where you will always find food debris and more bacterial contamination. Schweck pulpotomy has a great prognosis. Okay, because of this flat surface, it leads to a hyperplastic or a proliferative reaction of the pulp. And this keeps the inflammation very, very superficial. The depth of the prepared cavity retains the medicament very, very well. This helps provide a bacteria tight seal, it aids healing of the pulp tissue, and the pulp cavity allows placement of the restorative material and an excellent hermetic seal. This child presented 2 weeks after trauma. So for 15 days, the pulp was exposed. For 15 days, saliva was contaminating the pulp. For 15 days, food debris, saliva, so the pulp was getting contaminated, right? So it was greater than 9 days, and it's a huge exposure. Look at the huge exposure. So I did not want to take a chance. I cannot do a Schwedt pulpotomy here. So I did a full coronal pulpotomy. It's the same thing. You just go and remove all of the coronal pulp tissue, control the bleeding in the same way, hypochlorite, saline pellet, moisture control, no blood clot, place the MTA, calcium hydroxide or biodentine there, then the resin modified glass ionomer, then etch, bond and fragment reattach or do a direct composite build-up. This is a very old case, so there was no paralleling radiograph, but try and get a good radiograph each time. And because I had the fragment, I reattached. This is another favorite subject of mine because whether it's the primary teeth or the permanent teeth, being minimally invasive, and both the doctors here yesterday had beautiful lectures on minimum intervention and caries, which is again a very, very favorite topic of mine. So minimal intervention, no matter what the age. If I broke my tooth today, I want the dentist to be minimally invasive even in my tooth, right? Because the less you do, the more you keep for the future. So very, very quickly, fragment reattachment, we have no time, but the rule for fragment reattachment is you do a traditional etch and rinse system, always. So you etch the tooth, you wash, you dry, moist, gentle dry, and apply the bonding agent, but do not cure. The trick is do not cure the bonding agent. Again, etch the fragment, bonding agent on the fragment, do not cure. If you cure the bonding agent, then your fractured fragment will not realign well. So you scrub the bonding agent well on the tooth, scrub the bonding agent on the fragment, do not cure. Then you align your fragment to the fractured tooth with the help of flowable composite or your dual cure cement, align it and cure. That's about it. That's a fragment reattachment. It's fairly easy. If you do not like the aesthetics and you feel a little bit of the fracture line is visible, you can take a tiny round burr, make a gutter over the fracture line, etch it and put some flowable composite to mask it. Okay? So that is on 3 of follow-up. And remember, it's great, right? We've been minimally invasive. So trauma can be ugly. This is a little boy. He's only 7 years old. So when he comes to you like this, it's scary, right? For the parent, the child, it's scary for you. So you have to take a deep breath, make them wait in the waiting room, go and open your laptop, Google IADT Guidelines 2020, look for the rules, and then go in and address the situation calmly. So what do I see here? I see this tooth, a young permanent tooth with a huge pulp exposure. What am I going to do? A simple pulpotomy is all that is required. It looks horrible, but all you need is a simple pulpotomy, which is what I did. And no matter how badly fractured the tooth, I will still do a direct composite build-up. In young teeth, I will not put a post. I will not do anything aggressive. I will not do full coronal coverage in an 8, 9, 10, 11, 12-year-old. It's too early, the child is too young. Yeah, and our composite resins are great today. The technology is so good that as long as the child does not pull and shear from the front teeth, your direct composite build-ups will stay fantastically. So that is on to your follow-up, and look how well the tooth has matured. Root development is the strongest indicator of pulpal healing, and here you see how the tooth has healed, and here there's literally no root. The tooth was so young, there is no root there, and you remember how terrible the trauma was, and look how wonderfully this tooth has matured, right? There, you see the root maturation there, and that is the biodentine plug, that is the resin modified glass ionomer, that's the composite resin. Now, in some cases, I will do an extended pulpotomy. That means I remove the coronal pulp tissue, but it is still